What's up, everybody? This is Dr. Zach Baker of Rehab to Perform and R2P Academy, and you are listening to the Strength in Knowledge podcast. Today we have with us Dr. Tyler Betteridge, sports resident from our Germantown location, and part of the residency is monthly research article reviews, and this month we're learning about the shoulder. So Tyler, do you mind talking a little bit about the article that you chose and why you chose it?
Sure. The article that I chose was called Shoulder Instability, Performance, and Return to Play in National League Hockey Players. The purpose of this study was to investigate the incidence of shoulder dislocations in the NHL and the subsequent effect on return to play and player performance that those types of injuries have. I picked up ice hockey in my mid-20s, picked it up just recreationally, playing an old man league locally, and it's something I really enjoy. Always been a big hockey fan. And additionally, my younger brother just recently had a shoulder surgery, so I was curious to kind of see what return to play and performance metrics look like in trying to return to play in hockey.
Awesome. And I think if you've worked in an outpatient clinic in a sports med environment, you've most likely encountered somebody with a shoulder instability incident, whether it's a dislocation or a subluxation. And it's probably about 50-50 in regards to how many of them went and got surgery and how many treated it conservatively. And there's a lot of different factors that go into that. And we'll kind of talk about that a little bit later as we progress through the article. But, their age, their competition level, the timing of the season of when it happens. Is this a first time or a multiple time injury? Is it a relatively isolated injury, or are there multiple structures involved? Was there some bony degradation? Was there labral involvement? Was there rotator cuff involvement? So a lot of different factors that go into it, but you can have success either way, assuming you're taking all those external factors in and you're putting them in the best position for success. When you're operating at the professional level, the stakes are a little bit higher. You miss time, that could be a loss of significant money. It could be loss of opportunity. And if it does not result in either one of those and you are playing, it could result in a poor performance if you do not rehab it and manage it appropriately. So pretty cool article. I'm glad that you chose this one. Do you mind talking a little bit? I understand this is more of like a retrospective study. Do you mind just talking a little bit about the details of who was included in this or how they did the study?
Sure. The cohort that they ended up looking at was 56 NHL hockey players with what they called a shoulder instability event. And they defined a shoulder instability event as a dislocation of the glenohumeral joint requiring a reduction. The average age of players was around 25. Their BMI was around 26. They had an average season played of a little over 10 and average game played of about 570.
Awesome. And then do you mind just talking a little bit about who was included in this? And then after that, just talk a little bit about some of the different metrics that they were interested in gathering.
Sure. So those who were included, they had to have had at least one instability event and played in at least one NHL game prior to the sustainment of the shoulder injury. The injuries that were sustained in preseason, postseason, in the offseason, during international play, or during a lockout season were excluded. And injuries that were sustained in the last 3 games of the season were not included in the season-ending injury analysis. So basically they just excluded any players that couldn't be determined as like true season-ending or career-ending injuries. Some of the primary outcome measures that they looked at in this study were looking at which players received operative versus non-operative treatment of the shoulder instability, what was their ability to return to play, what was the time required before return to play, so how many games did they miss, and what was their season of return, and then what was the presence of recurrence of injury as well.
Awesome. Now that we know what they're looking at, what did they actually find? Was there any big differences between the post-operative group, the non-operative group, in any of those metrics?
Sure. So the bottom line for this study was that in regards to total career games played, they found that there may be a benefit to early operative intervention as opposed to non-operative management. In the case of shoulder dislocations, there were higher rates of return to play and acceptable performance outcomes after instability events in professional hockey players in general. And the recurrent injuries, so those who had non-operative treatment and had a recurrence of injuries, that had a negative effect on their total career games. So they found a significant difference in total career games lost in the operative versus non-operative treatment groups. And it was also noted that of all the players who had operative treatment, none of them had recurrent injuries.
That's pretty significant. When you kind of dive into the statistics a little bit, it looks like they found 67 confirmed in-season shoulder instability events, with 9 recurrent instability events occurring in 5 different players. On average, there's a little bit over 4 confirmed shoulder dislocations that were happening per season in the NHL. That's kind of interesting to me. I would have thought that there was more than that, and maybe there were more and they just weren't reported. But that kind of stuck out to me. Of the 67 players who did sustain the injury, 26 or almost 40% of them, they ended up being season-ending injuries. But 98% of all the players were able to return to play after missing an average of 26 games. So you can say a little bit less than half ended up having season-ending injuries, but almost every single one of them, actually 66 of the 67 who did sustain an injury, came back to play. And then 50% of these players who had the season-ending injury, half of them, exactly half, 13 of them, ended up undergoing surgery. And then with that, we had noticed the individuals that did have surgery did not have a recurrent event, whereas the ones that did not have surgery, that was the cohort of individuals that unfortunately did experience an event. Any other statistics that kind of stuck out to you in regards to time to play, time loss, or anything from the surgical or non-surgical group?
Definitely. On that topic of the players that were able to, or on the return to play and games missed, they found that there wasn't a significant difference in games missed prior to return to play in the operative versus non-operative groups. So I just thought that was interesting because when you look at it from a big picture view, whether you have operative or non-operative treatment in regards to this study, your return to play timeline doesn't change very much, so you're not missing very many games, but your chance of a recurrence of injury is higher if you don't go through operative management of that injury.
Now, going through this article, as with any research article, there's going to be limitations. You can't control for every variable, and in this, they didn't try to. It was a retrospective study. And there's certain things that you just have to live with the level of imperfection, but you need to be aware of where those imperfections are. What were some different limitations that were either brought up by the article or ones that you thought of?
Sure. So anyone who watches pro sports knows that there's a lack of details when it comes to what is readily available to the public in regards to player injuries. So especially in the NHL, a lot of times when a player is injured, it either gets dubbed as a lower or upper body injury and no further details are kind of released to the public. So
I wish we could do diagnostics like that in the clinic.
Right,
What's
exactly.
wrong with my elbow? It's an upper body injury.
Yeah, for sure. So getting exact details on, injury management details, what kind of procedure was performed, how exactly the dislocations happened, all of these metrics that could tie into our treatment approach, and whether it be from the conservative or surgical side, are kind of hidden to the public. So I think that's definitely a limitation. Also, this is a pretty small sample size. They had a pretty large number of seasons that they looked at from
It's like early 2000s, like 03 to 2017.
Correct, yeah. So it was about 15 seasons minus the 2 lockout years that they looked at seasons. But in all, it was only 56 players that met the inclusion criteria for the study. So it was a relatively small sample size. And then as on the topic of lockouts, those 2 seasons further reduced our data set that was available in this study. Other factors that could have influenced the results of this study or the findings, the seasonal timing of injuries and individual player aspirations, and then also gameplay-related factors such as coaching decisions or individual player disputes that might have affected their return-to-play timeline. All of those kind of non-measurable variables could have affected this study.
Cool. Now, when we're talking about conservative versus operative management, the overall outcome at the end and the return to play decision making looks very similar because we need to make sure that they possess qualities in the clinic that are going to match up well with the demands that they're going to meet when they're back on the ice. Oftentimes, the decision to entertain surgery or try to do it conservatively, first off, it comes down to the structure and what we're dealing with. And you have a traumatic injury like this, sometimes the parts and pieces get so damaged that conservative management isn't an option. And you need to go in, you need to go surgery to actually give them a fair fight of trying to go back and play and not just be a shoulder that is waiting to dislocate again because it doesn't have the structural support to handle it. Then, when you do have some of the injuries that come in that you get the x-ray, you get the MRI back, clinical presentation looks pretty good, you think that you are able to build this individual back up and tolerate ice hockey again, you go through a plan of care, and then there has to be some testing at the end to figure out, did we achieve what we were intending to achieve, and is it logical to put them back on ice? Not even making the conservative versus surgical approach, but just thinking end-stage rehab, trying to get an individual back onto the ice. What are some things following a shoulder dislocation that as a clinician, you would want to make sure you're checking these boxes before you put them back on the ice?
Sure. So I think like with every injury, we got to hit the basics first. Are they achieving full range of motion or range of motion within normal limits? Are they maintaining a low symptom profile? Do their MMTs look good? Are they showing adequate strength, appropriate strength? And has a proper healing timeline elapsed?
Perfect. And I think with those are the basics. And those are the things that we're going to do more demanding tests. We're going to do more functional sports-specific activities. If we can't even pass these grade 1, 2, and 3 exercises, it doesn't make sense to go on to grades 6, 7, 8, and 9, and then 10, 11, and 12 in regards to intensity. So make sure they have a low symptom profile. If they're still complaining about pain, they're still extremely fear avoidant, there may be something continuing to go on. If they don't demonstrate adequate range of motion, they can't handle basic, isolated, single joint, single plane, isometric testing from a strength standpoint. Good luck having them land on their arm. Good luck having them try to hit somebody or take a hit or have a slap shot. So make sure we're doing the basics first. We clear all of that stuff. Then what starts to come into your mind from like a more functional testing. I hate using the word functional, but we'll say more progressive testing with this individual.
For sure. So some things that I would want to look at here are they meeting standardized push-up and pull-up metrics? So when compared to their peers, are they being able to hit those kind of like baseline numbers? We'd also want to look at a few other of our special tests, such as our closed chain upper extremity endurance tests. So they have adequate upper extremity endurance and good weight-bearing capabilities in closed chain through their upper extremity. And then this being a shoulder instability injury, we would want to look at their measure, some sort of measure of stability and control through that arm and through that joint. So something like our upper extremity Y balance test would be able to give us a good measure of that.
Perfect. And I think mechanism of injury is very important to think about when we have this. When we think of a shoulder, there's two very big picture ways that we can think about stressing a shoulder. We can do it through compression, and we can do it through distraction. And a lot of times when we have shoulder instability, there's typically a heavy compressive force. So think of like a Fuchs injury or a direct contact, or there's more of a distractive force. And you can think about maybe we're in a combat sport, we get tangled up with somebody, we get some long axis traction and distraction that happens. Maybe we're a pitcher or a thrower who is doing high-intensity throws and we have heavy distractive demands. Maybe we're just lifting and we're in a position where we get a significant amount of traction that happens at the shoulder. So those play a very large role in the types of demands that we want to have in the clinic. If we have a Fuchs-type injury where we have a hand striking the ground and that resulted in instability, we want to make sure that we have some tests in our repertoire that look at how competent are we with our hand on the ground in weight-bearing compressive demands. That closed chain upper extremity stability test, it's a great entry point for that. We have both hands on the ground. We have them 36 inches apart, and we are alternating side to side, tapping the opposite hand. Both hands are pretty much under our base of support. They're going to be a little bit wider, but we only have intermittent bouts of single limb stability. If we pass that, then we can go into our upper extremity Y balance, which is true single arm stance. We are on one arm for the entirety of the test, and we are going through multiplanar, multidirectional loading. If you have never tried or you're not familiar with the upper extremity Y balance test, give it a try. Look at what it entails, and it is very tough, especially if you have a posterior dislocation, to fake your way through that test. Those two tests aren't the end-all, be-all, but they are two standardized tests that you can do that give you a lot of useful information. Other tests that I found to be valuable on top of these, if you have force plates, you can do your ASH testing protocol, or if you have a handheld dynamometer, you can do the ASH testing protocol with that, the athletic shoulder test. It is a test that essentially looks at your prone, I, T, and Y positions, and you can have the individual pressing into the plate or pressing into the dynamometer to see how much force they can generate. If you have an anterior shoulder injury, this is a very vulnerable position for the shoulder. So if we have any structural degradation to the joint, or we have any fear avoidance, you are going to see some sort of lacking performance on this test, either with asymmetry between the two or just overall force production. Other open chain tests that we could consider, maybe a prone cuff endurance test, lying on their stomach, on a bench or a plinth, arm out in a T position, so it is 90 degrees abducted, and they are holding a weight, roughly 2% of their body weight, ideally for 45 seconds. And this is going to stress the posterior cuff. So if you have a mechanism of injury where that's important, that is a great test. They are not throwing athletes, but may not hurt to do some upper extremity plyos with them. And whether you're doing wall dribbles, whether you're doing ball drops, or whether you're not doing a formal test, but just taking them through upper extremity plyos, that would be a really good way to look at rate of force development with intensive and extensive plyometrics to see how they do with all of that. Other things that I like to look at as well is, can they do just general athletic movement such as sprinting, change of direction, even if it's a quote-unquote lower body task? Think about all of the positions and the movements the upper body has to go through with sprinting. And you'd be surprised at how hard and how fast the arms have to work when you're sprinting, when you're cutting, when you're changing direction. Obviously, being on your feet versus skates is a little bit different. But then in addition to that, some more sports-specific tasks. How do they do with the stick in their hand? How do they do with just handling a puck, passing, shooting, getting back on the ice, and doing some of those preliminary measures? So, Tyler, I appreciate you taking the time to go through the research, do all the dirty work for us. I enjoyed listening to this article and seeing what you had to find. If you enjoyed this episode, please share, like, and subscribe, and stay tuned for our next episode of the Strength in Knowledge podcast.